Dr. Schmitz, Gillian needs any real introduction. I think everybody knows her. I've known her for a long time as she was active in the Council for Residency Directors, where she acts as an assistant and program director and has been very active in education. She does a lot with the military, but now has worked her way up the board of directors at National ACEP and is our current president. So we're very lucky to have her able to fly in to give us an in-person update. She was at Indiana yesterday, flies out to Texas today, and is doing multiple visits in a single week. So thank you for coming and gracing us with your presence. I look forward to hearing your update.
Absolutely. Well, thank you for having me. It's a pleasure to be here. I'm going to try to stand in the middle here so you're not moving your camera and making people seasick at home today. But I learned a lot about leadership this year. There have been a lot of challenges, but also opportunities in emergency medicine and with a specialty right now. And it's very interesting to me, if you go on social media or you read about where is emergency medicine as a specialty, of are we glass half full or are we glass half empty? Right, on one hand, we've got people really excited about the changes. The pandemic is ending. Look at what we've learned from the pandemic. We've exploded into telemedicine. How can we evolve beyond the four walls of a hospital? And other people who are saying, oh my God, this is crazy, and it's like lions and tigers and bears, oh my, right? CMGs, nurse practitioners, and HCA, oh my, the world of emergency medicine is over. And when I think of that, I don't know if my slide's gonna work here, is it really over?
Did you say over? Nothing is over until we decide it is. Was it over when the Germans bombed Pearl Harbor? Hell no!
German? Forget it, he's rolling.
It ain't over now. Because when the going gets tough, the tough get going. Who's with me?
So I feel like that some days. But I think about that. Is it over? Hell no, it's not. Was it over when we tried to introduce emergency medicine as a specialty in the House of Medicine? Does anyone know what the vote was? 100 to 6 that we lost, that people didn't want emergency medicine to be a recognized specialty. Was it over then? No, it wasn't. Was it over when we made the front cover of Time magazine? And if you note the date here, 1990, it was 30 years ago, when the cover was overwhelmed and understaffed. Medicine's front lines are collapsing across America. Does any of this sound familiar? The pressures from overcrowding, non-paying patients, drug violence, AIDS, and a nursing shortage are taking a heavy toll on today's staff and the patients, right? It wasn't over then, and it's not over now. We are just beginning. We are evolving as a specialty, and there are going to be some challenges, but that's who we are as emergency physicians. And anyone who knows me knows I absolutely love Ted Lasso. But the thing I've learned about leadership is that this is who we are as emergency physicians, is we look challenges in the face and we don't run away from them, right? We say, bring it on. Workforce issues, nurse practitioners, scope of practice, CMGs, let's just rip off the Band-Aid, let's dive in and let's fix it. Let's not run from it, let's not bury our heads in the sand, but let's approach these issues as we always do on shift when we don't know what's gonna come in the door. When the EMRs go down and we have to use paper charts and those dry white erase boards and go back to the 1980s, if we felt comfortable, we're probably not doing it right. And a lot about leadership, and what I think makes us uniquely qualified to lead a hospital, to lead an organization, is that we're actually pretty comfortable being uncomfortable and addressing some of these big challenges. So ACEP does a whole lot, and I don't have time to go through everything in 30 minutes of what we're focusing on. But the 4 things that I hear the most from our members that they are concerned about are workforce issues and job market, NP/PA scope of practice, the consolidation and corporatization of medicine, and reimbursement. ACEP is doing a whole lot on other things like mental health and opioid addiction and workplace violence, but we don't have time for that today, but if you're interested, I'm more than happy to go through that with you. So first things first, this has caught a lot of attention over the last couple months was the match. And people really concerned about this bottom number, that for the first time we had a 7.5% unfilled rate before the scramble, before the SOAP, and people panicking. And it was actually hysterical to read on social media the different perceptions, again, glass half full, glass half empty, of what was causing this. And there were a lot of people said, oh my God, right, the world is ending, people are abandoning emergency medicine and they're not applying to emergency medicine and it's just this mass exodus. Not true. Not true at all. Actually, the number of applicants was roughly the same as what we've been in the past. This is from sort of the mid-cycle year match, but what we saw was that the 2020-2021 year was an abnormal blip. And if you think about what was happening that year, right, we were in the middle of the beginning of the pandemic where we were healthcare heroes. The workforce data had not been published yet. So we saw this big surge. So if you look just 1 year to the next, that does look a little concerning. But overall, our numbers are actually on par for where we've been for the last 4 to 5 years. And we actually had more applicants this year than we did in 2019. So the reason we didn't fill had nothing to do with the number of medical students applying to emergency medicine or that we're not still one of the most competitive specialties in the House of Medicine. It's probably due to multiple different factors. One, we've been growing. We've had a 30% growth rate in the number of residency spots over 5 years. And that growth rate may not be sustainable. But two, it could also be programs who just didn't really plan well and who didn't write their match list as long as they probably should have. And all of those things combine the factor. But if we scare medical students away by promoting a message that everything is horrible, that will drop off, right? And we don't want to see that. We want to remain one of the most competitive specialties in medicine. So we want our message to be positive. So how are we addressing this? So ACEP has kind of been working with all the other EM organizations to address what we call sort of the 5 pillars. This first one is about to wrap up next week. And we've been meeting with all the other organizations every 2 weeks. Dr. Bond has been a part of that group of looking at how do we raise the bar on training for 2030? What is emergency medicine practice going to look like in the future? We were laughing earlier about ultrasound. When I trained, we didn't really have ultrasound. It was the blind leading the blind, right? A lot has changed because our practice has changed. Well, where are we going in the future? And how will that make it harder to start new emergency medicine residencies if we raise that bar? So I won't go into the details today, but these are many of the recommendations that we are going to be making to the ACGME, who ultimately has the decision of looking at the numbers and types of procedures, of looking at adding potentially new rotations, of redefining what a resuscitation is. A resuscitation is not one albuterol inhaler and you're out the door, right? We got to be a little bit stricter on how we look at that. Research requirements, not just for residents, but for academic faculty. And have we pushed the bar too low in scholarly requirements? Core faculty requirements. As we grow our training, should we make it required that every residency have an ultrasound-trained, board-certified physician on their faculty? We're probably there, right? What about pediatric emergency medicine? What is the scope and how do we raise that bar? And how do we scale the size of residencies to looking at the number of core faculty and protected time? There are now several emergency medicine residencies that are over 100 residents. As a former PD, I can hardly remember the name of 30 residents. When you get to 100, that's not a residency, that's an army. But looking at how do we grow in a responsible manner. Number 2 is we're ensuring that business interests do not supersede education or patient care. So it is no secret that many hospitals are stretched really thin on razor-thin margins right now. And a number of hospitals and health systems have been starting residency programs. And if you look, they're not just for-profit. It is nonprofit, it is public hospitals. Everyone is in the game of trying to expand their workforce, whether that's PAs and nurse practitioners, or expanding the number of residents to keep their costs of staffing down. So we're meeting with almost everyone on this list to have a kind of uncomfortable but frank discussion about how quickly are you growing. And I'm getting that feedback that they're listening. And we met with the CEO of HCA to say we need to have a discussion about the fact that we've opened 10, 15 residencies in one state, and in a matter of time, people are having a difficult time getting jobs in those geographic areas. And so they at least verbally claim to be responsive to that they're looking at slowing the growth of emergency medicine residencies and potentially even converting some of their GME spots from EM into other specialties where there is a deficit. And that is the impact and power that ACEP has, that other organizations don't, is the ability to meet directly with people who make these decisions. Pillar number 3, we're looking at scope of practice. So currently 20% of ED visits are seen by PAs or nurse practitioners. Last year, we joined the AMA's Scope of Practice Partnership to use a number of modalities in our advocacy efforts to talk about the difference in training between physicians, physician assistants, and nurse practitioners. And last month on Doctor's Day, we launched a national campaign and multiple little videos that talk about that difference. Now, ACEP believes in a team sport, that we're absolutely going to work with other providers in the emergency department. but we believe that every patient deserves physician-led care, and that we work together, but every patient needs to be at least seen or supervised by an emergency physician. And at a state level, we've had a number of advocacy wins, this year in South Dakota and just last month in Wisconsin, on prohibiting independent practice. And we're looking at rural communities. There's a number of jobs in rural areas, but emergency physicians have not historically been willing to take those jobs. Is it because they're uncomfortable practicing in an environment where they don't have neurosurgery and ortho and OBGYN? Is it because they don't pay enough? How do we incentivize emergency physicians to work in those areas so we raise the bar and quality of care in those remote critical access areas? So we're lobbying the government right now and looking at loan reimbursement to help medical students defray some of their costs of education, and of expanding the roles and rotations of our EM residents to practice in rural areas before they graduate. And this is the one I'm most excited about, is really expanding demand. So most people don't realize this, but we're not the first specialty to go through this sort of workforce crisis. In the 1980s, anesthesia had a huge surplus. When managed care came about, there was a lot of concern that there wouldn't need to be as many operative elective cases, and therefore they wouldn't need as many anesthesiologists. And people panicked. The number of medical students who applied to anesthesia plummeted, and for 5 years, half of their PGY or residents were international medical students because the attraction of US medical students plummeted. And then fast forward 10 to 20 years, you can't get an anesthesiologist now, no matter how hard you try. The pendulum has totally swung the other way. So what did they do? Well, they did two things. One, they realized we have to expand our scope beyond just airway. What if we got into pain management? And that exploded. And they evolved outside of the operating room, and they went into ambulatory surgical centers, and that also exploded. And now they are in such high demand that their salaries have gone through the roof, and even with CRNAs and other people providing care, they are in incredibly high demand. So maybe this is just part of our evolution. Where else can we go beyond the four walls of an emergency department? Avera Health is a telemedicine company that oversees 150 critical access hospitals, that from sort of this mega center, you can provide oversight and care across all of these rural areas of America. This is 2 miles down the street from where I live. It's an emergency hospital. It's an ED on steroids. They have 24/7 MRI, CT, ultrasound. They don't do admissions. This is all about being a rapid diagnostic center, which makes so much sense, right? 80% of the patients we see get discharged. We don't need more hospitals. We need more rapid diagnostic centers. And who better to do that than emergency physicians? So I'm really excited about where this is going. And we started a task force last month that's looking at all different kinds of options of, just like anesthesia, how do we expand our skill set and evolve beyond the four walls of a hospital? So I do think there's light at the end of the tunnel as far as workforce, and to provide a little bit of reassurance that I think we're headed in exactly the right direction. Another thing I'm really proud of, and many of you have maybe seen a little bit of a shift in flavor of what ACEP has become this past year, and I'm incredibly proud of that. And this came out of our strategic planning. And I will tell you that I am generally not a fan of strategic planning and writing vision statements and mission statements and sticking stickers to walls. But this to me was kind of the aha moment that I'm really proud of. On the top, we asked all of our staff and board members to take a red dot. And if you can't see, on one side of the screen we put specialty, and on the other side we put emergency physician. And on the top there with the red dot, we said, where do you think ACEP currently sits? Who do we advocate for? What is our mission? What is our vision of what we do? And you can see a pretty broad distribution, but we're kind of in the middle. And this is something that has been a challenge, because sometimes what's best for the specialty may not be what's best for the emergency physician. And what do you do when those things don't align? And so in blue dots, we asked the board, put us where you want to go. Where do we go in the direction? Who do we redefine who we are and what ACEP does? And this was a pretty fundamental shift, that clearly we need to go more towards the individual emergency physician. And this is not to say that we don't advocate for patients. Absolutely, that will always be our bread and butter. But I liken it to kind of when you go on the airplane, right, and they tell you to put your oxygen mask on first before you put your kid's mask on, is that we have to take care of ourselves. We have to preserve our own interests, because if we're not well, our patients are not going to be well. And those pieces will fall into place if we are advocating for the emergency physician. And so this was a big change, and I think a lot of what you're going to see coming out of what we've done this year is because of that change. I won't go into all the details of our strategic plan, but there's a really nice roadmap that looks at our vision for change. It's at acep.org/strategic plan. And it really, our goal, our vision for change is for ACEP to be your home and your community for professional fulfillment, and to help us help you be the best job in professional fulfillment you can be. Whether that's working clinically, whether it's running a hospital, whether it's doing research, whether it's advocating for your patients. Some of the things that have come out of this that I'm really proud of. We redefined how we use the word residency. So we believe that words matter. We absolutely value and work with our other colleagues in the emergency department, but a training from a nurse practitioner or a physician assistant is not the same as emergency physician. And so we've embedded this in our policies that the use of the word resident or residency training should be limited towards physicians. We looked at how do you define supervision. That's become a big thing that I'm hearing from our members is since my group got taken over, or as our hospital expanded, they're cutting physician hours, they're expanding nurse practitioner hours. How are we adequately supervising people in the emergency department? So 2-3 years ago, ACEP worked with all the EM organizations. We brought in AAEM and CORD and SAEM, as well as the nurse practitioners and PAs, and said, can we get everyone in a room? How do we define supervision? And how do we really, what is our recommendations of what's adequate? And the group, the task force of all of these organizations came up with 3 definitions. They said direct supervision is like what I do with my residents. I hear about and I see every patient in the emergency department. Indirect supervision is where I hear about the patient in real time. We discuss the management, but I may not necessarily see the patient or re-examine them. And the task force, and this can either be on-site in the ED or remotely via telemedicine. The task force came up with a 3rd category that they included as oversight. And this is where you have protocolized care, or where the emergency physician is available, but the PA or NP decides which patients they're going to staff and which ones they don't based on their comfort level. And I will say that ACEP really struggled with this when we went and reviewed this of what do we believe is adequate supervision. And after much discussion, we said that we don't really think oversight is supervision. If they're reviewing the facts after they're discharged, that's quality assurance, but that's not really supervision. And the problem with supervision is you don't know what you don't know. And if I'm legally required to see every patient that my PGY3 or PGY4 is seeing, why wouldn't I have the same standards for a nurse practitioner or PA who have less hours of training? And the pushback we got was, well, it's going to take too long. I can't possibly see every patient. We have PAs in our military hospital who have 30 years of experience. It doesn't take very long, right? It may just be I have a lac in bed 5 that I'm going to sew up and give tetanus. But there's some discussion so that when we have that pregnant patient, right, who comes in with nausea, vomiting, and the PA says I'm sending them home, and I can at least glance at their vital signs and say, hold up, that looks like preeclampsia, let's not send her home just yet. But there's some system in place that emergency physician has input into care of patients real time. And this is going to be challenging for some departments to meet that standard, but we believe it really is what's best for patients and quality. And we limited off-site indirect supervision to critical access hospitals or rural EDs, that the gold standard should really be an emergency physician on-site for every emergency department. And so we're looking at accreditation. Just like the ACS accredits level 1, level 2 trauma centers, how awesome would it be if ACEP could accredit all emergency departments? Do you have a room for nursing mothers to go pump? Do you have adequate supervision of your nurse practitioners and PAs? Do you have water? Can physicians actually go pee during their shift? How great would it be if we set the rules of what an emergency department should be? And so we've started a task force who's looking into the feasibility of how ACEP could build this. A month ago, we met with the Federal Trade Commission. We have seen widespread consolidation across all of healthcare, right? Insurance companies, there used to be dozens of them. Now, for all intents and purposes, there's 3 or 4. Hospitals are now health systems. Home Depot is the CMGs of hardware stores. We live in a capitalistic society, and everyone is trying to get more leverage, more economies of scale to save costs and to have more leveraging negotiating powers. But have things gotten too big? So the Federal Trade Commission is looking at this and wanted to know exactly what is the impact of consolidation, not just on patients, but on physicians, on the employees. How is this impacting your work? And so we asked our members to write in to tell us what they think and also contact the FTC. Tell us how it has impacted your practice, the quality of care, the cost of care, your supervision, your due process rights, so that we can be that voice for you. And we testified in front of the FTC a week ago. I signed my letter yesterday, which will go to the FTC today and will be publicly available. And there was a mix of comments, but overall a very negative theme of how physicians are interpreting this increased consolidation, whether it is a corporate group, whether it is an academic hospital becoming a health system, that the decisions are being made now not at a local level, but outside, sometimes even the state, that they feel like they are a cog in a wheel. They don't have a voice, and that their due process rights, the transparency in billing, much of that has adversely impacted their practice. And so we are speaking very loudly about how we correct this and how we look at market forces that address these changes for both horizontal and vertical integration. And with that, last week we issued a statement on private equity and corporate investment in emergency medicine, that we are concerned about this consolidation. We are concerned about a business plan that uses private equity investment with a goal of flipping a hospital in 3 to 5 years with short-term investment gains on long-term stability of our practices. And I think this is a really pivotal change of where ACEP has historically been, and something that I'm very proud of, that we are listening to our members, that we are standing up to what we believe is right for our patients and for our physicians. And as part of that, we're really advocating for transparency, right? This is about building trust. And not every group is the same. Not every small democratic group is good. I worked for one, we had 0 transparency in billing. We had 0 due process. Not every private equity group is bad. There are many groups that offer due process, that offer transparency in billing, regardless of how they're financed. So maybe we should be judging people by their behaviors, not who their employer is, of how do they treat their physicians, what do they offer. And everybody wants something different, right? To me, due process and billing transparency may be really important. To one of my residents, it may be an adequate maternal leave. But maybe we want everyone to be able to have that choice and that transparency, that we fight for these really basic rights for emergency physicians, regardless of who owns the contract. And so now anyone who advertises or exhibits with ACEP is asked to complete this checklist. If these are ACEP's policies, do you comply with them, yes or no? And it is scannable with a QR code when you come into our exhibit hall to see what they have and what they don't, because we want to be able to really negotiate and empower physicians to have what they want in a contract. Last month, we launched a campaign on the value of emergency physicians. If you haven't seen them, they're on YouTube. I think they're fabulous. They're little 1 to 2 minute snippets that you can use in your state advocacy efforts, to use with patients, to use with the public, to use with your legislators, on what differentiates an emergency physician and how is our training and experience different from other people in the emergency department. We've had a number of legislative wins. And so this year, in the state of Georgia, this is crazy, they had a list of 600 diagnoses that the insurance companies said, that's not really an emergency. We're not going to pay you for that. On that list, DKA, chest pain, vaginal bleeding. And we're like, well, hold up a minute. Like, you didn't know that it was this, and that's crazy. The whole point of emergency medicine is that people don't have a diagnosis, right? They come in with a constellation of signs and symptoms. You can't decide whether or not you pay for something after the fact looking at a final diagnosis. It's called the prudent layperson standard. And so we sued, and we won. And that will help all emergency physicians. It's kind of like whack-a-mole. You knock down one law in Georgia, a new one springs up in Florida or North Dakota. But once you have a win in one state, we can use that advocacy in different states when these come up to challenge the prudent layperson standard. We had a second win with Virginia with the same thing. CMS wanted to downcode anything that was on a list of non-emergent diagnoses. And on a national level, we had a really big win this year. We have been fighting this for 5 years now on out-of-network surprise billing. And we looked at when insurance companies come back and say, I'm going to pay you $10 for that chest pain. You say $10, right? I can't afford to keep my lights on for $10. I need at least $100 for that chest pain. And the insurance company says, take it or leave it. This is our best offer if you want to be in network is $10. You're like, well, okay, I guess I'll be out of network because $10, that isn't going to work for me. And then what would happen historically is the patient would get billed that difference, that $90 of a surprise bill. And we got vilified as being, quote unquote, the bad guy, that we're overcharging. When really, in many cases, it was just the cost of care. And so the law that was passed said we have to have an independent dispute process where we take the patient out of the middle. And there has to be some sort of fair agreement that it's not $10, it's not $100, but can we come to a reasonable compromise? That was the law that was passed, but then the way that it became implemented said, we're just going to let the insurance companies decide what they think is fair. We think that's a pretty good rule. And we said, no, that's really not okay, because insurance companies will always pick the lowest level they can pay regardless. And so we sued the federal government, which is really awkward when you work for the federal government. But I have a little bit of umbrella from ACEP that it's not Gillian Schmitz suing. But this was a really big deal. And so we worked really closely with anesthesia, with radiology, with the AMA. This was a very well executed multi-state process of us working together to see this to victory. And we're punching way above our weight class, fighting insurance companies that have way more money and power and advocacy than we do. And we're winning, and I'm pretty excited about it. So a few months ago, the government ruled in Texas that the physicians were right and that the insurance companies didn't get to carte blanche decide what is the reimbursement rate. And we have until Monday for the government to appeal. If the government doesn't appeal, we have won our lawsuit, and we will then wait to see how they are going to replace that, with what words are they going to reimburse us. But this has been an ongoing issue for 10 years now, and this alone would have been a pay cut of about $50,000 to $100,000 of every single emergency physician in the country had this not been fixed. So this is a huge win that many emergency physicians don't understand the intricacies of, but this is a big deal about finding a fair way to compensate us for our services. And lastly, I'm really proud that we actually helped pass the Lorna Breen Health Care Act. Many of you know Lorna Breen was an emergency physician in New York who sadly took her own life and never had a history of mental illness. We know the pandemic has taken a lot out of us. We know the change in culture and seeing 3 patients an hour and working nights and days and flopping takes a lot out of us. We have to have resources. We have to be able to ask for help without being penalized for that and having judged by our ability to look for that counseling. And so this bill is going to provide a number of resources. It's going to destigmatize mental health and enable physicians to get the help that they need. So going back to my Ted Lasso thing, I am very optimistic about where ACEP is going, where emergency medicine is going. I'm not going to lie to you and say that everything is rainbows and unicorns. Yeah, we have some challenges ahead of us. There's going to be some short-term volatility. But I look at that and I say, bring it on. Because that's what we do as emergency physicians, right? When that bus of hemophiliac kids crashes outside our ED, when the bomb goes off outside and we're getting ready for the mass trauma, this is where we shine. And this is where we should be most proud, that we take on these challenges, we embrace them, and we go into it running head on of how do we fix them. Because that's who we are as emergency physicians. We are problem solvers, we are fixers, and we're gonna get through this. It's short-term volatility for long-term stability. And just like we did in the 1960s, just like we did in the 1980s, we're gonna get through one crisis at a time. If there's anyone who can do this, it's us. Thank you guys very much.